Computer is a bit on the slow side today. Apologize. Probably time to get a new one. All right. All right. There we go. Good morning. A nice potpourri of different tracings today. All righty. So, why don't we start here first with Dr. Kansan. Good morning. How are you?
Good morning. I'm good. Thanks. How are you?
Thank you. Okay, so let's name the catheters. We're looking at the LAO projection of a patient who's having a standard SVT ablation. Let's see if we can figure out what we're looking at here. So let's start here. Whoops, sorry about that. Let's start first here. Where is this catheter, do you think? A.
This is the high right atrium.
Exactly right, correct. Where's this catheter here that's labeled C?
Is that one the His catheter?
Indeed it is. Very good. What is B here? It's going posteriorly.
Oh, is that the coronary sinus?
Yeah, right. Because remember, this is an LAO projection. So presumably the atrial septum is sort of here in the middle. Anterior on this side, posterior on this side. And then finally, where do you think this catheter is labeled D?
Is that one the RV? Oh yeah, because it's below D. I mean A. So yeah, is that the RV one?
Right. This is the RV catheter, right? It's a little posterior in the right ventricle, but yes, it's in the right ventricle. And of course, you can tell from this still frame that this is one of Dr. Love's cases because he typically uses a coronary sinus catheter that's deflectable and placed from the groin, whereas, as you guys know, I usually will put one in from the neck in the IJ. And here's the ablation catheter, Tulsi. So if you saw that the catheter was in this location, what would you say this location is actually? Where is this catheter, the tip here?
The AV node.
Well,
or in between. Yeah.
Well, where is the AV node normally located closer to?
The
like, why do we?
Oh, the His. Oh, yeah. Okay.
Right. So it's normally near the His. So where is this closer to? This is the coronary sinus catheter here. So it's very close to the mouth of the coronary sinus, right? So
okay.
you would say that's the it's usually the posterior septal region of the right atrium. So that would correspond to, so this could be an ablation that we're looking at for a pathway that's located near the posterior septal region, or this might be Dr. Love adjusting the catheter to do a slow pathway modification in the lowest third of Koch's triangle, which is sort of in this general vicinity here. But very good. Okay. So we don't really, in a lot of labs, they're not even using fluoro at all anymore, but you can see this exact same projection on Carto as well. So, okay. All right. Let's see who we got here in our gallery here of people. Interesting crew. I see Dr. Perna Bonsall on the line, all the way from Florida. Morning.
Good morning, Dr. Bass.
So, Ms. Bonsall, or Dr. Bonsall, what am I saying? A little tired this morning, it seems. What do you think is going on here in this rhythm? There are two unusual findings in this tracing, so on this patient. So I want to know what's going on. If you were going to interpret this electrocardiogram, Robin Berry needs to put it into the into epic, what are you going to tell her is the interpretation of this tracing?
So I'm looking at lead 1, 2, 3 AVF.
Mm-hmm.
Seems like sinus rhythm with a pace, what seems like a pacing spike that I don't appreciate in lead 1, but lead 2 just before the P wave.
Mm-hmm.
The rate is 4.5. So 5. So rate is around 60.
Mm-hmm.
Regular, looking at the rhythm strip right now. And the QTC looks long, but I don't know if it will come out long. It seems like there is atrial pacing.
Mm-hmm.
And I'll calculate the QT real quick.
So one of the nice things about calculating QTs is that at a heart rate of 60, the measured QT is typically equal to the corrected QT.
Oh.
Yeah, that's a good rule of thumb. It's largely true.
Then 11 times. So it's around 440. I don't know the age, but seems fine.
I think it's actually a little longer than that, actually. I think it's more in the 480 range, actually. Is this a normal QT morphology? What do you think about this morphology when you're looking at it? Or this one here?
Sorry, I can't see.
What do you think about the? What do you think about the position of the T wave in relation to the QRS? This isoelectric period here.
So normally you say that if it is the QT itself is more than half of the RR interval, it's roughly a sign of long QT.
Yes, that is a rule of thumb, not a guarantee, but yes, it's a rule of thumb.
Yeah, it's almost looking like half to me, so that's why I didn't say long QT from the very beginning. Yeah, but yeah, it does.
Go ahead. I'm sorry to interrupt you. I apologize.
No, I was saying that's what I was thinking, that it does look long. And that's why I counted, and I'm getting like almost 5, 6, 7, 8, 9, 10, 11 small boxes.
I think it might even be a little longer than that. It might even be 12. So, or somewhere in between there. You know, the other thing, and the point I'm trying to raise is that, you know, as you look at more electrocardiograms, you become, excuse me, you become more used to seeing what a normal morphology looks like to the QT segment. This is a very, very abnormal appearing QT. Forget about the interval, which you and I can quibble about whether it's long or on the borderline of long, and I certainly understand why you're calling it 11 boxes. It could be close to that. But what's very abnormal appearing is this extremely long isoelectric period between the QRS and the peaking of the T wave. And that should sort of prick up your eyes when you're looking at the tracing. When you see this type of, so you know, when you're trying to make the diagnosis of long QT syndrome, which this patient does have, you want to also look at the morphology of the T waves and the QT interval. And this is a very, very abnormal appearing, QRST segment, right? You have this very long isoelectric period with this very late peaking T wave. Lead 1, it's pretty obviously strange and unusual looking. If we look in lead F and in 3, we almost can't see where the T wave ends, could end all the way out here potentially. So when it's not always just the interval. Clearly, if the interval is long, well, then the diagnosis is pretty clear, but the morphology of the T wave also. So in this case, I agree with you that the QT interval is long-ish, but it isn't super long. But the morphology of the QT segment is so abnormal in appearance that that fact, in combination with the length of the QT interval, is highly suggestive of the diagnosis of long QT syndrome. Do you have any thoughts on why this patient might be apaced with this condition?
Mm, I'm not sure.
Well, go ahead. I'm sorry. I was about you about to say.
I'm saying that, I mean, if the patient has a defibrillator,
Mhm.
they have pacemakers also. So, or if you are on a beta blocker because you're being treated, that's why your heart rate is low.
Right. That's exactly right. So a lot of times patients with long QT, in order to get a good amount of beta blockade, become so bradycardic that they might benefit from atrial pacing. And that's the case in this patient. This patient is essentially apaced all the time. I think is programmed AAIR with a lower rate of 50. And so, yeah, sometimes, so when we're putting and this patient presented with torsade actually initially. And it's an interesting case. When the patient presented, they were very young, maybe 7 or 8 years of age. And a number of instructive points about this case. First of all, the patient presented was on vacation at the beach and fainted and was taken to an emergency room. And basically no electrocardiogram was performed. The patient was just examined and sent home. And the next day, went home from this vacation. It was a local trip, and fainted again in their home. Went to a different emergency department where an electrocardiogram demonstrated that the patient was having torsade and long little runs of polymorphic VT. So the doctor out there who was affiliated with the hospital I was working with at the time quickly faxed me a tracing. And the interesting aspect of it was that most of the 12 lead was in torsade, but there were like 2 beats that were in sinus rhythm. And this was about 20 years ago now. And I could tell, it looked like this. I could tell that the QT was very long. So I quickly ran to the phone and called him, the cardiologist, and I screamed into the phone, "Do not give amiodarone," because, you know, most PALS algorithms call for the administration of amiodarone in the setting of ventricular tachycardia. I personally have always had a bit of an argument with that recommendation because in the pediatric population, VT is very commonly, or is more commonly, due to things like channelopathies than in the adult population, where VT is more commonly due to myocardial infarction and resultant ventricular arrhythmia, in which case amio makes a lot more sense. So, so I was lucky in that I was able to catch a patient. Why would I not want to give amio to this patient with long QT syndrome, Perna?
Because if you have long QT type 3, you could further increase the duration of, I don't know, you could further delay the phase 3, something like that. I'm sorry.
Okay, so you're sort of on the right track.
Yeah.
Well, one of the manners in which amiodarone works is prolonging repolarization. If you remember amio, when it was first introduced as an antiarrhythmic, the ads used to say the only drug with all 4 Vaughan Williams category effects. So it's a calcium channel blocker, a beta blocker, a sodium channel blocker, and a potassium channel blocker. And so amio works by prolonging the QT. In fact, I think it would be fair to say that many antiarrhythmic agents work in part by prolonging the QT. This is one of these things where a little bit is good, a lot is bad. And so the last thing that you would want to do to someone who has long QT syndrome is give amiodarone, because amiodarone prolongs the QT, and the expectation is that the small amount of prolongation will in fact aid in as an antiarrhythmic agent. You know, a little bit is good, a lot is bad, but you would not want to give it to someone who has an abnormality in repolarization, because it will enhance that abnormality and make it could potentially make the VT worse or unstoppable. So you would never ever give amiodarone to a patient with long QT syndrome of any type. So at least in 2022, that would be a strong recommendation. So if that patient, so let's say that you were me back in 2002 and you got this tracing with polymorphic ventricular tachycardia, and you were lucky enough to see 2 beats that had a long QT interval, what would you tell the person on the other end of the phone in terms of what to do for this patient who's having torsade and whom you think the patient has long QT syndrome? What could you do acutely to try and get the patient out of tachycardia?
Good cardiovert.
You could cardiovert, but if a patient is going in and out of an arrhythmia and is spontaneously starting and stopping, cardioversion wouldn't really prove to be very helpful, right? Because the patients themselves are stopping it and is demonstrating that they keep going back into it. So I would not cardiovert. Yes, if somebody was in ventricular fibrillation, of course, you would defibrillate them. If somebody was in consistent and unstopping ventricular tachycardia, you would cardiovert them, but you would not cardiovert somebody who's going in and out of it because they're spontaneously stopping on their own. So what medical therapy could you potentially give a patient with long QT who is essentially having torsade right in front of you?
Magnesium helps in torsade.
Yeah, you could give a dose of magnesium, never a bad idea. Anything else you could give? Would not object to that choice.
Esmolol infusion?
Yeah, you could start an esmolol infusion. That's often helpful in this, and you'd probably want to ratchet up the dose rapidly. As you know, the half-life of esmolol is very, very short. It's in the range of less than 2 to 3 minutes. So you'd start at maybe at 100 mics, go to 200 mics, or even 300 mics. Let's say that also was helping, but the patient continued to have little runs of torsade intermittently. Anything else you could add to that as you're calling for transport to the big hospital transport? You could give lidocaine also, right?
Okay.
Lidocaine might be helpful if it were a sodium channelopathy, which in this particular case, it is not a sodium channelopathy, or at least not to our knowledge. But you could give lidocaine. It's unusual. Lidocaine, you know, we know the side effects of lidocaine, such as neurological symptoms like paresthesias and tingling, could even cause seizures. But if dosed properly, you ought not to get too much of that. It may not work, but there's almost no harm to giving lidocaine to a long QT patient. So, and in fact, in this particular case, the esmolol was very helpful, as was the magnesium, but the patient continued at that time to have episodes. And so we added lidocaine, and then the patient stopped having tachycardia entirely. And so in the end, we ended up treating the patient with a combination of beta blockade as well as mexiletine, even though genetic testing never did uncover a sodium channelopathy. And on that combination, as well as implantation of a defibrillator, the patient has never had a documented episode of tachycardia in about 20 years. So the interesting question is whether or not this patient needs an ICD at all. And could you, after 20 years demonstration of never having an episode, never having a recorded arrhythmia or a shock from the device. If the device were to break, if the lead were to break, should the patient have the device replaced? It's an interesting question. Thankfully, at this time, the device continues to work well, so it's easier. I don't have to make that decision, but one could make the argument that if after 20 years of therapy with a combination of atrial pacing, beta blockers, and mexiletine, if the patient's never had an arrhythmia, could that be adequate in and of itself? I don't know the right answer to that question. It's not an easy one. So,
Dr. Pass, quick question.
Sure.
Why do you see pacing spikes in only certain leads like 1 and V1? I don't see.
Right. So the reason for that is the same reason on any EKG why we sometimes see things in some leads and not in others, which is that sometimes in a particular axis, we're not able to see certain things on the electrocardiogram. It's the same reason why in lead AVF, we don't really see the obvious ends of the T wave, but in lead 1, we can, right? It's because when you're looking at the heart from multiple different directions, electrical directions, sometimes one lead will be easier to see something than the other. And so, I'm glad you asked that question, because oftentimes, in fact, I think you yourself are like, well, I don't see a pacing spike in 1, but I see it in 2, 3, and F. And I was wondering if you were thinking, that maybe there wasn't pacing. I mean, if there is a pacing spike in most of the leads, then chances are it is being paced. But, I agree, like if you were to just have V1 up, you would not know. This gives you a good example of why it is that I don't love it when all we have is like one rhythm strip from a monitor, because if I just showed you lead V1 and I said, what rhythm is the patient in? You would say they're in sinus rhythm. But if I showed you lead 2, I think you would say a patient is in atrial paced rhythm. So it's important to always look at multiple leads, but if you're seeing pacing spikes in a lot of different leads, the chances are the patient is being paced. Also, in this particular electrocardiogram machine, all the leads are simultaneous. That is not true, by the way, in all machines. Usually the 12 lead as displayed up here is all simultaneous, but in some machines, the rhythm strip on the bottom may not be simultaneous with what's going on above it. You always want to sort of check your particular machine. In our case, our machines, the rhythm strip is always simultaneous with the tracing above. All right, this is a 12-year-old patient who presents after a syncopal episode, and trying to figure out what is going on here. I'm going to ask Dr. Barris what he thinks about this.
So just taking a look here at that rhythm strip in V1 on the bottom. And, I'm seeing, changing PR interval. And the question is, are we in complete heart block, or what else might be going on? It doesn't look like the R to R interval is changing too much. So I am going to, and then what was the evaluation for 12-year-old female?
Came in with a history of syncope when she was having her blood drawn.
Yes, I mean, because the RR doesn't look like it's changing, I would say it's probably complete heart block.
I would agree with that statement. What do you make of the axis of the QRS?
So it's upright in 1, and it looks like it's upright in AVF. So I'd say normal. Yeah,
it's normal. So, so sometimes people would say that this is like, some people sometimes refer to this as a junctional escape rhythm. I don't personally agree with that because we don't really know what the junctional rate would be, because there's complete heart block and we don't really know what if there would even be His-V. It's clear, though, that the escape rhythm is a high ventricular rhythm because it does have an axis similar to that of sinus. So it's probably arising high up near to the level of the bundle of His. So if you saw a patient in your office, Dave, who had fainted and this is the tracing, let's say you got a phone call from a pediatrician's office, said, would you be willing to see the patient today? You say, sure, send them over. You get this tracing. What kind of evaluation would you do? What would be the things you'd be concerned with?
So you'd want to take a look for Lyme, hypothyroidism, echocardiogram, maybe looking for like CCTGA that for some reason was not diagnosed until 12.
What else would you be looking for on the echo? Any other potential things you might see?
Like maybe like a myocarditis,
Yeah, you could have myocarditis. So you probably would want to send inflammatory markers as well. It turns out that in this particular case, the patient's mother actually has lupus. So if the patient had fainted, would you? So you've done the echocardiogram shows a structurally normal heart, a little bit of dilation, normal heart function. All of the blood work is negative. What would you do at that point with this patient who had syncope at the site of blood?
I feel like it's at the site of blood, but I feel like if she was symptomatic, she would get a pacemaker placed.
That's right. A symptom of fainting would generally be considered an indication, a class 1 indication for somebody with congenital, what we would assume is congenital complete heart block for a pacemaker. It is interesting, though, that the wrinkle in the story would be at the site of blood, because it does also sound a little bit neurocardiogenic, right? But probably most people in a 12-year-old with complete heart block who doesn't have an acute cause of it that's potentially reversible, like myocarditis, probably they would favor putting a pacemaker in such a patient. So if I saw this patient in the office, I probably would admit them to the hospital until I could find time in the cath lab to put a pacemaker in that patient. So this is a patient I would probably pace if that were the story. Good job, Dave. All right. This is a 12-year-old who has atresia of the right coronary and has a coronary fistula that is dumping into the right ventricle and the distal right coronary is arising from this fistula, unusual anatomy. And this is the 12-lead electrocardiogram. So I am going to ask Dr. Kong, Dr. Grace Kong, that is, not to be confused with our other Dr. Kong. What do you make of this electrocardiogram, and do you have any concerns in this tracing?
I see that we become quite bradycardic. If I had to calculate a rate, it's definitely less than 60. Say almost like 40s. I'd have to do this 60,000 divided by the cycle length to get the
heart rate's at the low 50s, but
okay. It is sinus rhythm, and the axis looks normal, and the T waves looked actually fine.
Okay. The other thing I should say, just as a corollary to what I mentioned to Perna before, just as the QT interval, the corrected QT interval is equal to the measured QT interval at 60, when the heart rate is less than 60, the QT interval corrected will be shorter than the measured QT interval. And if you sit down and do the math, you'll see that. So if you have a normal measured QT in a patient whose heart rate is under 60, the likelihood of the QT being prolonged is essentially 0. Just a good rule of thumb. But anyway, please proceed. Sorry. I agree with you. QT is normal.
And I'm trying to see if there's any other, in terms of rhythm, anything I'm missing. Maybe in V3, I thought there was an additional P wave, but I don't really see it. Oh, actually, yeah, I don't really see it anywhere else. I think it's just a T wave.
Agree with you.
So with the history and the sinus bradycardia, although it does pick up later in the strip, maybe it's a brief bradycardia.
Do you notice
the PR interval?
What's going on with the PR interval?
Yeah, yeah. The PR interval seems to be lengthening there. Not enough for me to see. I don't. The strip doesn't go far along for me to see if there's. But even if so, it would be Mobitz 1 happening there.
I agree. It looks like we're about to have an episode of Mobitz 1 there. So what do you think about someone whose right coronary is atretic and whose distal distribution of the right is coming off of a coronary fistula, who has this combination of sinus node? Seems like we have some sinus node dysfunction, right? Because normally we would not see a 12-year-old who's sitting at a resting heart rate of 50. This is not a very athletic patient. And we're also seeing somewhat, what do you think about seeing some Wenckebach in somebody whose heart rate is, on the right-hand side of the screen, it's no more than about 65, right? What do we think about Wenckebach when we see it in an awake patient?
Unusual.
Yeah, it's a little unusual and a little bit worrisome.
Maybe
So
the branch supplying the sinus node area coming off of the proximal RCA.
it usually does, right? In most human beings, the SA node artery is usually from the right coronary.
I don't know if the AV nodal area is also.
Well, the distal right often can, the distal right can supply the AV node. So it's an interesting question of whether this could potentially represent some problem with perfusion of the sinus node and the AV node. Some people, it's been posited that, when we do a slow pathway modification, we're burning in the lowest third of Koch's triangle. And some people have wondered if we are in fact knocking off little distal branches of the right coronary and it's supplied to the slow pathway, and that's how it works. I don't think that's true, but it is an interesting theory. But I think the point I'm trying to make here is that when I saw this tracing, I got a little bit nervous about the fact that maybe this was some indirect evidence of ischemia to the sinus node and also potentially to the AV node. And so if you saw this, what would you, this is a chronic problem, by the way. This patient has been known to have this apparently their entire life. What would you do to evaluate this, Grace? Let's say this is the first time you've noticed this in this particular patient.
I would still do the same things that David had mentioned earlier for the heart block evaluation. I would still send probably Lyme and TSH and inflammatory markers. I would get an echo. I would definitely do a Holter to see if there's any higher degree block and see what the average heart rate is for this patient and see if there's variability that's appropriate.
Yeah, that's right. So that's pretty reasonable to do that. Yeah. I did send the patient a ZO monitor to see what's going on with the rhythm over long periods of time. I probably should have sent those tests. I did not in this patient. But it's an interesting observation in somebody who might potentially have right coronary perfusion issues. So I thought this was interesting to share. All right, I'm going to cut it short today. I have a few cases in the lab, and we have sign-out in a short while. Thank you all very much for joining. Hope everybody has a great day. And we're on again this week for for Thursday morning, I think. Is that right, Grace? I think so.
Yes, that's correct.
Okay, looking forward. I'll see you then. Take care,
Thank
everybody.
you.
Thank you, Dr. Path.